Good morning, everyone. At the outset, I would like to thank the organizers for giving me this opportunity. So, without wasting much time, I'll directly move on to my case presentation. I'm going to talk in my presentation about a post-operative retinal fold. Before moving into the case, we'll have a one basic introduction slide. So these post-operative retinal folds are classified basically into a tractional, non-tractional, and then hypotony-related chorioretinal fold. So my topic, I'm going to focus only on the non-tractional variety. Among the non-tractional variety, there is something called inner retinal fold, outer retinal fold, as well as full thickness retinal fold. Among the full thickness retinal fold, again it is classified into two things. One is dry full thickness retinal fold, another one is full thickness retinal fold with subretinal fluid. So this is outer retinal fold, this is inner retinal fold, and this is full thickness retinal fold with subretinal fluid. So in my first case, like a 54-year-old female presented with a poor visual acuity gain following a scleral buckling for a phakic macula of. She underwent a buckling surgery for uh, uh, subtotal RD, phakic subtotal RD, where the break was located, just above, superior nasal quadrant, just anterior to the equator. This patient, we took to the surgery and then we performed a scleral buckling. After seeing the.
मतलब सॉरी माइक में बोलो सॉरी माइक में बोलो सॉरी
So this patient we took for the surgery and then we performed a scleral buckling. So with the help of 277 in the superior nasal quadrant, and then the drainage retinotomy was done in the inferior temporal quadrant. So intraoperatively we found a little bit hypotony, and then we have injected a air bubble, as well as there was a drainage retinotomy site subretinal bleed complication was noted. So this was the post-operative peak where the retina was settled, but unfortunately there are two full thickness retinal folds were noticed. One is starting from the disc margin and then extending temporal to the fovea. Another one is just above the superior arcade. The corresponding OCT shows full thickness retinal fold with subretinal fluid. So we counsel the patient, and then we have taken for the surgery to resolve this complication. So this is like we waited for another after about 4 weeks, but still patient the full thickness retinal fold didn't resolve on its own. Hence we have taken for the surgery. So in this surgical video, I'm going to show you. So in this, we completed the vitrectomy. After completing the vitrectomy, we just stained the ILM with the help of BBG. And then after removing the BBG, we completed the 360-degree ILM peeling around the fold. So once we completed the ILM peeling, then with the help of 38 gauge Med1 subretinal cannula, we just injected a BSS plus solution. The amount of BSS plus solution is almost like it should be injected in such a way that the full thickness retinal fold should resolve on table only. So there is the most important precaution at this step is we are not supposed to inject the subretinal BSS exactly on the fold. Either it should be above or below where the retina unfolds on its own. So without any much manipulation. After in this video, we can see that step very beautifully. After this, like we just completed the surgery by doing fluid air exchange and then SF6 gas tamponade. So this is the post-operative day peak. So at the time of presentation, the visual acuity was 1/60, and then there was a full thickness retinal fold with a subretinal fluid. In the after 2 months post-operative peak, the retinal folds are completely unfolded, and then the OCT shows a very residual fold. It was much better than the pre-operative. So similarly in one more case is there, like in that condition there was a dry retinal fold. In this patient underwent a PPL PPV and then buckling for a traumatic RD 2 months back, and then at the time of presentation he had a visual acuity of 2/60, and there was a full thickness dry retinal fold which is involving the fovea. Again we repeated the same step, same surgery was performed, and then after 1 month the dry retinal fold was completely resolved, and then patient visual acuity was improved to 636. So there are certain predisposing factors for post-operative retinal folds. One is the most important thing is the superior bullous RD, either air or gas tamponade, immediate post-operative heads-up posture, residual SRF, or else incomplete non-drainage, or incomplete drainage, or else non-drainage techniques. So another one is like scleral buckling with air or gas bubble injection. And last one is giant retinal tear. These are the most important predisposing factors for the post-operative retinal folds. So management. So prevention is always better than cure. So hence the most important step in these conditions is immediate post-operative prone posture, irrespective of the break location, is going to minimize all these uh, retinal folds. So if there is an inner or else outer retinal fold, just we have to observe. If there is a full thickness extramacular folds, again we have to observe. The third thing is like asymptomatic full thickness dry macular folds. Again, nothing has to be like required, just to observation is required. Third thing is if patient is symptomatic with full thickness dry macular fold, then PPV, ILM peel and then subretinal BSS with gas tamponade and then followed by prone position is going to help us. If there is last condition where the full thickness tractional macular fold with subretinal fluid is there, then again we have to repeat the procedure to relieve these folds. So in my second case, a 23-year-old female, diminution of vision from last 10 days, which was sudden in onset and painless, and she was diagnosed to have a aplastic anemia and admitted in our medical department for about last 3 weeks, and then she complained like diminution of vision from the last 10 days. So at the time of presentation, her visual acuity was 3 by 60 in the right eye and 6 by 12 in the left eye. The fundus examination shows multiple white-centered as well as dot blot hemorrhages and along with the premacular bleed, especially in the right eye, which is about 2 disc diameter. So this is the enlarged peak where we can see a 2 disc diameter blood which is covering exactly in front of the fovea. So this is the OCT which shows localized hyaloid detachment as well as the subhyaloid blood. So we performed before going into this thing like a PPV, we just performed India laser hyalodotomy. I think it was some 4-5 years back where when we started doing India hyalodotomy at our center, we started with the 2 millijoule energy and then 2 or 2 4 spots are required. In our center, we have a Apasami as well as the Goldman 3 mirror contact lens, and then 2 or 3 spots is more than enough to do the procedure. So this is the serial picture after the procedure. This is taken after 5 minutes, this is after 10 minutes, and this is 15 minutes, and this is after 20 minutes. In all the pictures, the blood is trickling down into the vitreous cavity. So this is after 3 weeks post-operative film. First one is at the time of presentation where the visual acuity was 3 by 60. After the procedure, after 3 weeks, the visual acuity is improved to 6 by 60, and then we noticed a full thickness macular hole with the migration of the blood into the subretinal space. This is a known complication or whenever we use higher energy or else we exactly hit the fovea with the help of laser, then these complications are notorious to happen. So we published this case in IJO. So, and then after learning from this mistake, and then we have performed about 9 cases. So where like the
Basav, we'll come to that. We'll come to that. We'll come to that. So thank you. Sorry, I'm going to try and be as like that. Thank you, Basav. I'm going to first start the discussion with the second of your cases, which is the YAG hyalodotomy for premacular bleeds in patients who might not be able to undergo surgery, are not willing for surgery, or for whatever the reason might be. Just going to throw it out to Samyak. I'm going to pose this to you. If you were to offer this to somebody, short of vitreous surgery, what would be your case selection? Who would you offer this to? Just any patient with a premacular bleed? What would be your thoughts on this? Any takes? Any pointers for this? Coagulopathies? What's your take? Can we get a sorry? एक detachable mic है आपके पास?
Hello. Yeah. Thank you, Mohit. Good morning, everyone. So first thing first is most of these patients would have some coagulopathies. So we want the patient to be stable before you take up that patient for surgery. That would be my first criteria. Second, you should be able to validate that this is not spontaneously improving and it is causing a major loss of vision. For example, at times it will be bilateral involvement. So you want to at least mobilize the patient in a way that the vision starts improving. And I think about 660 counting finger vision to 636, I think would be
Would be your indication to manage.
yeah. And on the OCT, you will be serial OCTs. You will be seeing, of course, how the fluid is being resolved, how things are getting.
Fair enough. I think so. Again, Basaf, just one last question regarding this to you, and then we come on to the retinal fold thing. Given that you had one macular hole in one of the cases, and then you went on to do 8, 9 others and did not have any, what would be your 2 or 3 pointers that you would say that if this is the size or extent, or you should do it or not do it?
Sir, like at most, caution is like we have to use minimal possible energy. Like we have to avoid the fovea. Like we should avoid the hitting the fovea. Either we have to consider most dependent part depends on the foveal location, depends on the blood location. It should be reserved for at least a 3 disc diameter, more than 3 disc diameter subhyaloid bleed. The third option is, sir, we have to try in other areas with the patient head posture adjustment. So because of that thing, we can avoid these foveal related complications. The ERM and other complications, it's not there in our hand, but at least this complication we would have prevented if we use a little bit precautions.
So size is the most important factor you're saying. Anything smaller than within the arcades,
More
and if
than
it's not
2
high
disc
enough,
diameter.
you'd run the risk of that happening. Fair enough, fair enough.
See,
We-
the my point is most of these patients are very young, like in their 20s or maybe you can say 15 years old or maybe up to 25 or 30. See, the risk of development of cataract, the risk of developing you can say of detachment in their life, glaucoma also. So putting all these complications, you can say, or to avoid all these complications, I better prefer to just observe only. Whenever any development of ERM or pucker is there, then it's good for me to go and intervene. But conservative management is the, you can say, for the, if you see the long life of the patient, it's not good. These are very, very adults.
Point taken, sir. Absolutely, very well. I think there is no urgency. We can. I think all of us agree on that. It's in the blood's in the premacular space. There is no rush to go in and do anything. But there is a argument to be built if it's bilaterally, macula affecting, and the low HB, the low platelets is not going to get back, is not going to get better in a jiffy. He has aplastic anemia. He has other things. He might have a truncated lifespan, during which you would want to try and get his quality of life better. Or he might get better because of, let's say, he got dengue related or some infection related his platelets are low, and they might be able to get that better in a 4, 5, 6 months time. In that patient, you might want to wait, but if it's bilaterally affected, you might want to try and get his life better there. But absolutely agree, there is no urgency. It's not like blood in the subretinal space. We can observe it. One last point, Simar, and then we're going to move forward.
Baswa, if you were to take home something from this, do you think the location from the fovea would be a factor in choosing when you want to do it and not? Because this was relatively, I think, within 500 microns from the foveal center where you chose to laser.
Simmer, the simple thing like fovea is like if you divide the disc into 3 parts, one the upper one third, middle one third, lower one third. The fovea is in the lower one third. It's a common sense we have to avoid that area. If we want to do a laser hyalotomy,
Do you think that was a factor in this one in causing the hole?
the factor if
Or
I
was it just the
if I
contraction that caused
no
the
if
hole?
if I speak frankly, the factor is like I have given this to my fellow, so he was inexperienced and then he just did it, and then this complication happened. After this, like when we are taking all kind of precautions because of that thing, I have done 9 cases. None of the cases have any complications. Every patient has got 6/6, 6/9 vision. So I think it's better to like review ourselves.
Is there any distance from the fovea that you would recommend to
So
do this?
at least 1 disc diameter away from the fovea in all the directions. Wherever you want, you can do, but you have to alter the head position.